Welcome to This Week in Infectious Disease. This week we're covering 10 notable papers spanning antimicrobial therapy and stewardship in resource-limited and hospital settings, prevention through vaccines, vector control and supplementation, and infection in immunocompromised and chronically infected hosts. Let's dive in. We'll start with two papers that speak directly to how we choose and de-escalate antibiotics. In the Lancet Infectious Diseases, the ACT South Asia trial tested whether adding cefixime to azithromycin improves outcomes in uncomplicated typhoid fever. Busnett and colleagues randomized more than 1,800 adults and children across Nepal, Bangladesh and Pakistan with suspected or blood culture confirmed typhoid to 7 days of azithromycin plus cefixime, or azithromycin plus placebo, in a properly blinded design. The composite treatment failure rate was identical in the two arms, at about 5% in each. In the smaller subgroup with culture-confirmed disease, failure was numerically lower with combination therapy, around 11% versus 16%. But that difference was not statistically significant, and the trial provides no evidence supporting the combination. Adverse events were the same in both groups. The practical message is clean. Azithromycin alone remains the treatment of choice, and adding a second oral agent buys you extra cost and extra selection pressure without demonstrable benefit. Alongside that, Clinical Infectious Diseases published a randomized trial from Kim and colleagues comparing standard blood culture workflow against standard workflow, plus a rapid multiplex molecular panel run on positive blood cultures, with antimicrobial stewardship support in both arms. Among 418 patients, the median time to the first effective antibiotic modification fell from roughly 65 hours to about 23 hours, and that advantage held for gram-negatives, gram-positives and yeasts, in and out of the intensive care unit, and during off hours. Persistent bloodstream infection was about half as common with rapid testing. Importantly, there was no difference in 30-day mortality or length of stay, so this is a stewardship and pathogen clearance argument, not yet a survival argument. That matters because of the third paper in this group, the acorn hair cohort in the Lancet Infectious Diseases, which is the largest prospective picture we have of resistant healthcare-associated infection in Asia. Mo and colleagues followed nearly 10,000 patients across 41 hospitals in 19 countries, with hospital-acquired or healthcare-associated bloodstream infection or ventilator-associated pneumonia. Just under 3/4 of infection episodes involved resistant organisms, and gram-negatives dominated. Crude 28-day mortality among resistant infections was close to 38%, rising above half for carbapenem-resistant Acantobacter. Attributable mortality was highest in ventilator-associated pneumonia, in children and younger adults, and in lower middle-income countries. Perhaps the most sobering detail is therapeutic. Most carbapenem-resistant gram-negative infections were still being treated with carbapenems or polymyxins, which tells you that access to newer beta-lactam, beta-lactamase inhibitor combinations, not just diagnostics, is the binding constraint in much of the region. Turning to prevention, three papers approach the problem from different angles. In JAMA, the ZIPS2 trial randomized 100 Ugandan children aged 1 to under 5 with sickle cell anemia to 20 mg of daily zinc sulfate or placebo for 6 months, on a background where all participants were on hydroxyurea. Namazi and colleagues recorded 80 all-cause infections in the zinc arm versus 124 on placebo, which works out to roughly a 40% reduction in the infection rate after adjustment, with no adverse events forcing discontinuation and no loss to follow-up. This is a single-site trial of 100 children, so it needs replication, but it is a cheap, safe intervention layered on top of hydroxyurea in a population where infection still drives mortality. On the vaccine side, the Lancet Infectious Diseases reported a Phase 2, a trial of SF2ATT15, a synthetic carbohydrate conjugate vaccine against Shigella flexneri 2A, in Kenyan adults, children, and 216 infants who received it alongside routine measles, rubella vaccination. So and colleagues used an age-descending, dose-escalating design testing, 2 and 10 microgram doses, with and without aluminium adjuvant, with safety and infant immunogenicity as the co-primary outcomes. Given that Shigella is a leading cause of childhood diarrheal death, and an increasingly resistant one, advancing a conjugate candidate into the target infant population in an endemic setting is the key step here. And on vector control, a cluster randomized trial in the same journal tested a dual-action insecticidal coating containing micro-encapsulated pyriproxyfen and alpha-cypermethrin, applied to indoor ground-level water containers in Cucuta, Colombia. Cardenas and colleagues randomized 20 clusters of roughly 2,000 households each and reached almost 90% of eligible households. Over 12 months, dengue incidence in intervention clusters was cut by roughly 45% relative to controls, with substantial falls in house infestation and pupae per person indices, at an estimated direct cost of $2 per household per year. A single application at that price point makes this a credible complementary tool for endemic urban settings. The final theme is infection in compromised and chronically infected hosts. Clinical Infectious Diseases published the EIPA study, a French multi-center retrospective cohort of 262 solid organ and stem cell transplant recipients with infective endocarditis, propensity matched against more than 1,500 non-transplant controls. Kachera and colleagues found a distinctly different microbiology. Staphylococcus aureus led at a quarter of cases, followed by enterococci and coagulase-negative staphylococci, with fewer streptococcal cases and more enterococcal, coagulase-negative staphylococcal, gram-negative and fungal endocarditis than in matched controls. Timing mattered. Fungal and coagulase-negative staphylococcal disease clustered in the first post-transplant year, streptococcal disease later. Transplant status independently raised 1-year mortality by roughly 70%, though 90-day mortality was no different, suggesting the excess risk accrues over the longer term. The actionable point is that empirical coverage in a transplant recipient with suspected endocarditis should be shaped by how long ago they were transplanted. Also in Clinical Infectious Diseases, Fisher and colleagues reported a 10-center prospective cohort of 819 pediatric allogenic stem cell transplant recipients, followed for 180 days in the era of routine adenovirus PCR surveillance. Among surveyed children, adenovirus infection occurred in about 27%, and anemia in about 16%, with proven or probable adenovirus disease in roughly 1 in 9 of the whole cohort. The attributable case fatality rate among those with disease was about 14%. Notably, children who were both adenovirus IgG positive and stool PCR positive before transplant had an infection incidence above 50%, which offers a practical way to identify a high-risk group for enrollment in future antiviral trials. Rounding out this theme, 2 HIV papers ask how much care and how many drugs are actually necessary. In Clinical Infectious Diseases, Shivite and colleagues randomized 321 virologically suppressed people with HIV categorized as low complexity to annual versus standard 6-monthly visits over 2 years. Virological control was essentially identical, around 86% by intention to treat in both arms and above 97% per protocol. But I want to be precise here. Formal non-inferiority was not statistically demonstrated against the pre-specified margin. What the trial did show was a significant rise in patient satisfaction and a roughly 25% reduction in HIV-related direct costs with annual visits. Treat it as encouraging but not definitive. And in open forum infectious diseases, the CARAVEL cohort followed 304 people in routine French care, starting dolutegravir lamivudine, both treatment-naive and switching while suppressed. Around 90% of treatment-naive participants achieved suppression by 6 months with no virological failure, and 94% of switchers stayed suppressed. Only 9 pre-treated participants had virological failure, with a single documented M184V emerging in the setting of non-adherence, and weight change was not significant in either group. If you only have time for one paper this week, make it the ACT South Asia typhoid trial in the Lancet Infectious Diseases. It is a large, rigorously blinded trial that answers a question clinicians in endemic settings face daily, and it settles it in favor of the simpler, narrower regimen. Here are the key takeaways from this week in infectious disease. First, for uncomplicated typhoid fever, azithromycin monotherapy stands. Adding cefixime did not reduce treatment failure. Second, rapid molecular panels on positive blood cultures cut time to effective therapy by roughly 2/3 and reduced persistent bacteremia, but did not change mortality or length of stay. Third, resistant healthcare-associated infection in Asia carries a 28-day mortality near 40%, and most carbapenem-resistant gram-negative infections are still being treated with carbapenems or polymyxins. Access to effective drugs is as urgent as stewardship. Fourth, cheap prevention delivered. Daily zinc cut all-cause infection by about 40% in young Ugandan children with sickle cell anemia, and a $2 insecticidal container coating cut dengue incidence by nearly half in Colombia. And fifth, In transplant recipients, both endocarditis microbiology and adenovirus risk are shaped by time, since transplant and pre-transplant status. Let those factors drive your empirical and surveillance decisions. That's your roundup for this week in infectious disease. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.